So we will begin with our set of questions directed to our panelists. I would like to begin with Dr. Kishore. So Dr. Kishore, when we talk about rural India, we understand that rural India is home to the majority of the country's population, yet mental health care continues to remain a significant challenge there. So how do you assess the current state of mental health services in rural areas, and what, according to you, are the biggest barriers to access?
So thank you for inviting me to be a panelist in this session. I think India as a country, I would say, will be very fortunate by the fact that we have a very, very good community-based program in the form of a district mental health program, which comes out of the National Mental Health Program. The program is ideally developed to reach out to the rural poor by the following things: integrating mental health into general health services, building capacity for people who man the primary health centers, reaching out to people in far off villages to deliver care at home, bring in all the resources of the Anganwadi workers, healthcare workers, and other peripheral workers to deliver effective mental health care program. And in some states in the country, there is a program which is meant to serve the people at home, what is called as the home care program, which has a very, very clearly defined criteria. Despite all these advantages, I still feel sad that close to 70-80% of these people do not receive care. So it is the administrators and the policy makers who have failed the people rather than the design of the program. For example, running mental health programs in taluks, in district areas, is going to limit people coming into these services, because an average primary health center area is about 15 square kilometers in our country. It ranges from 5 to 15 square kilometers, and distance becomes a very, very important barrier, and they will not be able to mobilize people with mental health problems to reach out to these places. Wherein the primary care staff are geared to provide mental health care, and the emphasis on reaching out to people, the last mile person in the village, somehow have failed because doctors and other people have chosen to work in easier settings like taluka places, district places, where the proportion of people who are likely to come and use these services will not be more than 20%. So therefore, 80% of people are left untouched, unheard, and those voices do not matter. And as a result, the burden, worsening poverty, distress increases, and a significant number of these people with severe mental health problems also become homeless.
Correct. So these are very pertinent issues that you mentioned, which become the gaps between a policy, curating a policy and implementation on the ground. So taking this forward, Jasmine, we often see two extremes. Either it is like romanticizing rural life or imposing an urban model of mental health care. So what are some of these biggest misconceptions about mental health according to you in rural India? And how do you think that these affect policy and intervention designs?
Sure. Thanks for the question, Aishwarya, and thank you for inviting us. I think there are several misconceptions when it comes to rural community mental health. The first one being there is a certain romanticized idea of rurality, and then assumption that there are no problems, specifically mental health problems, because you assume that there is a very strong community connect. The reality is that, I think just like Dr. Kishore was mentioning, that the treatment gap or the mental health care gap is that the same situation exists in rural communities. So almost essentially out of 10 people, only 2 people can access the care that they need. So the 8 that we are missing out happens to be from all of our communities. And this problem is resonating within the rurality, within the rural context as well. The other concern that we have been seeing is that somehow suicides are not somehow seen in our, or the misconception is that there are no suicide-related deaths in our rural communities, which again is a myth. There is some data to show, which probably I wouldn't get very data heavy at this point in time. The second misconception is that mental health is seen completely as an individual issue. And that's where I think we want to change the narrative to say that this is a psychosocial issue, which means that it's not just the individual that's getting impacted, but the individual is part of a larger ecosystem, a larger structural realities, which are impacting their mental health. So if you're looking at concepts around poverty, unemployment, gender-based violence, all of these have a relationship on mental health. Our health systems, unfortunately, are designed. I don't think I quite share the same optimism with Dr. Kishore here for the systems in which we operate, because the health systems are not designing for self-care or informal community care, which really is the base of the pyramid where we know that the need is the highest. Nicely so that they're also low-cost interventions, which can be done at a larger scale. But a lot of our investment with our health systems is falling within, waiting for people to fall more and more ill before we provide any support. So there's little that's being done for preventive, promotive, evidence-based interventions that actually we know can work and can be implemented. So the other concern with the mental health lens being an individual lens is that we forget that it's an intersectoral, intersectional issue. The third misconception is that somehow mental health is only the responsibility of mental health professionals, whereas we know that the solutions for mental health need to come from all sectors, because the problems for mental health are coming from intersectoral approach. So if we don't address social justice, social welfare, gender-based issues, then clearly we are not going to solve this big mental health care gap problem, which is not just a rural issue, but also an urban issue, but more so in rurality. What we've seen is health systems are designed to be, like I think was mentioned earlier, that they are far away services, they're not available, they're not accessible, and just not affordable as well. So yeah, maybe I'll just pause there.
Right. Thank you, Jasmine. You touched upon some structural factors also, like caste-based violence, gender discrimination, and migration. So, Dr. Kishore, I would like to ask you that these structural factors also shape mental health outcomes in rural communities. So, according to you, how do these stressors complicate mental health challenges, and how should interventions adapt to address them?
Yeah, a complex question indeed. Actually, any mental health program should be so designed that it reaches all categories of people, focusing on preventive, promotive, and of course, curative services. It is very well taken that curative services in general is a small portion that we have to deal with, while preventive and promotive services should receive a lot of attention. Somehow, preventive and curative services is not attractive to a large number of people, including the community, unfortunately. So, community is not ready to take up these services. Professionals are not willing to implement these services. So, the barriers that exist are true. In a context of village, distance, caste, lack of access to care, lack of roads, lack of transportation facilities, lack of an accompanying member to the hospital, or the hospital not being functional at a time which is suitable for people, or some of the barriers that exist. But in reality, I would think that the primary healthcare system should be geared so much so that it reaches out to people at their doorstep and delivers care. Uh, for example, when the first rural mental health program started in Nimhans, way back in the early 70s and 80s, it was found that 80% of people could be provided care in the context of a primary health center catchment area by reaching out to people on foot to their respective homes. As a result, burden on the family significantly decreased, stigma discrimination decreased significantly, employment for people with severe mental illness increased, the treatment gap was reduced to mere 20%, particularly for those people with severe mental health problems. And these were the people who were tied, shut in their own homes, often chained. And these were the people who require hospitalization because community care is no more suitable for them. And out of this, out of the 20%, that close to 50% of people were hospitalized. That is, 10% of people were moved into the community, and of course, only 10% remained untouched. So these are the advantages which got ultimately translated into the district mental health program in Bellary, where the total coverage for all mental health problems in the primary health center context was at that time 42%, the highest level covered so far. But now the coverage is the epiphenomena of people coming to taluka district hospitals, and that is less than 20%, is a very sad commentary. So even though the orientation for the doctors who join the service, health workers who are recruited into the primary healthcare system is done in good earnest, it is not getting translated into a pure community-based organization like several other projects which has been demonstrated within the country because of lack of motivation on the part of people and inadequate staff to supervise the whole thing, and being convinced that this is the way forward to deliver a package of mental health services so that people get benefit out of it, the burden reduces, stigma discrimination disappears, and so on and so forth. So the problem therefore is, I would still insist the problem is with the policymakers, bureaucrats who implement this program rather than the design of the program, because the design of the program is to reach out to all people with mental health problems as early as possible, being the first objective of the National Mental Health Program. Train all people with respect to mental health service by providing the skills and increase community participation. And all these three objectives remains to be met even till today, despite 45 years having lapsed from the time we spoke about this program.
Right, right, Dr. Kishore. So you have emphasized very specifically on community participation and a community model of intervention. So as we also talk about a lot of realities, the ground realities in rural area, one inevitable reality that we cannot ignore is migration, right? Out migration from rural areas. So we do understand that migration is draining the rural workforce with many elderly and vulnerable individuals who are left behind without caregivers. So, Jasmine, would you want to shed light on what happens to those who stay back and how does the lack of familial and community support impact their mental health? And as we were talking about community-based models, do you think that there are any community-based models that can address this particular gap?
I mean, yes, migration is an issue. But I think the larger gap that one is talking about is, I think, this caregiving role and who should perform it and where should it come from. So our view, I mean, the intervention that was mentioned earlier, the Atmiyata intervention kind of takes the view that communities can be enabled to provide support to each other for their own mental health and social care needs. That this caregiving role is inherently present within our communities. It's already happening, and we wanted to tap into the existing social capital. So there are systems and networks that we do need to leverage if we truly want to be community focused. So the part of that conversation is the health system's response, but I think our interest was in looking at the community ecosystem, where I think that there are strengths of people who are already problem solvers, who are already working towards solving problems for their own communities. Of course, the challenge is that sometimes how these communities get defined is on the lines of their caste, gender, religion, and so on. But despite that, the fact that there is an ecosystem that we could tap into without giving it the lens and the framework of a clinical model. And I think that's the big shift that we need to make. Mental health does need to be taken out of this professional gaze of a certain clinical or a medical model, as it's called, and actually look at it from a social model of care. So the idea of care in itself perhaps needs to be challenged a little bit more, where we do see pathways of care that are already being done. And we, through Atmiyata, actually wanted to tap into that caring pathways, equip people from the communities to give them the skills that they could use in their day-to-day life to reach out to members of their own community, provide solutions at their choice of location, not have to travel so much, and actually get their care in their homes. Having the confidence that this will be confidential, this will be a private conversation. But it's really about changing the conversations to a slightly more, to an evidence-based approach. So there are certain pathways that we could build, which is using a lot of our knowledge of what has worked in the past, what is the evidence that we have. A lot of these interventions, a lot of these conversations are not purely clinical. These are about supporting each other and being connected to each other and having empathy in your own communities. So I think that's what we wanted to harness and say that caregiving in itself needs to happen at the community level, not waiting for a professional to sort of come in. And clearly with the gaps that we have, a professional is probably not going to come in. But more importantly, what we've also observed is even if professionals are available, people are actively choosing to not go to these professionals. And I think that's a different story there, which is that I don't think the solution that's being offered to me works for me, or the language that I would need from my professional is acceptable to me. So I think there is a larger problem in putting one size fits all kind of a solution. And we do need to meet people where they're at. So if somebody trusts their friend more to have that mental health conversation, we need to find systems and processes to equip, the peer network to be slightly more responsive. If they're reaching out to maybe their teachers or their families, then what interventions can we do there to provide care more effectively, which is more acceptable to people? And that's the only way we can try and reduce this gap. Because we've always had the district mental health program, and clearly people are not seeking services. In our experience of working across 3 districts, most of the people our volunteers will reach out to have never sought a professional help, because maybe that's not a conversation that's happening in healthcare settings. So how do we enable these conversations to move to more informal spaces? And how do we make these informal spaces more responsive, more helpful for people who are looking for care? So yeah, I suppose I know that the question was who is going to take on that caregiving role. For me, it's the community itself. And I think there's a lot to tap into.
Right. I'll have a very similar question to you also, Dr. Kishore, because when we talk about community participation or we talk about community being the caregiver, we're also talking about uh, like a solution or the way forward to this. So you also spoke about the limitations of professional mental health care providers in rural areas. So do you think that this community-led interventions could actually be the way forward that we're looking at, or do you have examples of such interventions that have successfully improved mental health outcomes? And also, according to you, how can these be supported and scaled up?
There is no doubt about the fact that community involvement can bring in a lot of change at the level of service utilization, at the level of participation in the community, at the level of seeking the benefits of schemes that is promoted for the rural poor, particularly as Jasmine mentioned about citizenship role, disability, travel benefits, elderly care, providing support, peer support, and so on and so forth. But the challenge in the whole thing is that this particular phenomena has been recognized as an uniform need across the country, but the participation can vary from one place to another. So I would therefore think that proactively we will have to reach out to people with mental health problems rather than preparing the system to deliver that kind of care where people can come and participate. Of course, people's participation is important. When I was part of the district mental health program, I was the first person who wrote about the following things. If an ordinary citizen is not able to access drugs, or is not able to access disability allowance or disability certificate or a particular kind of program, he or she has the freedom to contact the district collector or the deputy commissioner of the district to say, these are my problems. If you look at the DMHP manual, information in the form of telephone numbers were available in that program itself. But how many people actually tried to use it? Very, very few people. So the utilization of these services also requires some amount of assistance because people with mental health problems, their families with mental health problems have lost hope that anything can happen significantly, and they will require constant support. If such a support happens, yes, as you said, participation will increase, outcomes for treatment for mental disorders will increase because the participation has increased, and continuity in follow up also increases. Yet, a large number of people will require other kind of assistance. For example, we at the Banyan have created what is called as the carer allowance who have to fulfill a particular criteria. After having used the carer allowance as a scheme to help people, the participation has significantly increased. About 20 years ago, Banyan introduced a small amount of 400 rupees as the disability allowance for people who were using mental health services after being homeless for a period of time. And the follow-up rate for those people was clearly more than 70%, while in the general population setting, the population will not, the follow-up rates will not be anything more than 20 or 25%, maximum 30%. So there is a very significant jump in the way services are utilized if you empower the community, open up access to. I would still think that the system will have to reach out to people proactively rather than opening up the system so that people can come and use these services because those barriers continue to exist. And if we are able to create a cadre of people like the peer supporters, volunteers, or people, young people in the village who could provide the support, educate people, actively assist families in reaching out care, it goes a very, very long way. So the entire construct of a district mental health program should be so robust that it should cover services, it should cover voluntary assistance, it should develop linkages to schemes, it should offer services of a special kind, and in situations where people cannot access, care has to continue at home. Close to 1/3 of people with severe mental disorders will clearly benefit from only home care, and this is an undisputable fact.
Right, Dr. Kishore. So you mentioned about system reaching out to people, but if we also look at it the other way, about the awareness around mental health issues and mental health disorders in rural areas, would you like to shed some light on that? Do you think that there's still a long way to go, or do you think that people are becoming more and more aware of it and trying to reach out to the system themselves?
See, if you understand pathways to mental health care, a person's mental health problem is recognized, that is, deviance, abnormalities in behavior, is picked up in less than 1 day. So within a couple of days, they reach out to either a traditional healer or faith healer. Then they move to another carer. So on an average, there are 3 carers seen in a matter of 1 month for severe mental disorders. So the recognition of the problem is not in doubt at all, because the abnormal symptoms are so distressing that people recognize. But the problem is a primary health center is located at least 3-4 kilometers away from the residence of the individual. They will find it physically difficult to persuade this patient. That is where the local community support is going to be important. So the awareness that mental problems manifest as behavior disturbances exist, but whether a medical system is going to be the solution, Ayurvedic system is going to be the solution, or other alternative therapies or faith healing is the way forward, is something that people will have to decide. But what we need to say is both the dawa is important as well as dua is important. So we will have to combine both of them and help people, because ultimately all of them combined together is going to be more helpful and robust than one particular pill or one particular injection or one particular consultation. And the socio-economic change that the country is going through, value system change that the country is going through, we need to have multiple levels of interventions for the community so that mental health services become relevant as well as effective. So the components of mental health care that includes reaching out to people, identifying the problem, providing them the right solution, continuously following them up. Unlike physical health problems where the dropout rates can be as high as 50 to 60%, with mental health it will be much higher. One is people recover and they don't want to go back because they say, I am well. Or if people don't see change, they'll say, this treatment has not benefited me, and I will accept this as fate that is decided by God, and therefore I'm not going back to the system. All of these things requires prolonged handholding and support, which means increase in the number of human resources, that is the interface between the community and the system.
Right. Thank you, Dr. Kishore. So I would like to ask the same question to Jasmine as well, since you have also worked on ground. So what has your field experience been? How do you think people have they been more accepting of it, or how do they consider mental health if we talk about people from rural India?
Yeah, I mean, I think I always struggle with this whole awareness question. I feel people are aware. My concern has been that nobody is listening to the ways in which people are talking about their mental health conditions. So, for example, in our rural experience, people are more than willing to share what might be distressing to them, what might be causing stressors, tensions. And I think that is the language that is what we all anyway used. And that is the language that maybe one needs to meet rather than impose, a diagnostic sort of a framework, which perhaps is not even that helpful. So my sense in the years of work that we have put in the rural communities has been always that people are willing to talk and share and talk about their distress. So I actually am not a big fan of these awareness campaigns to just say it's okay to talk, but I think our realization is it's okay to listen and it's okay to provide some amount of support as well. Because we're asking people to open up and share information and share their personal experiences of distress and leave them where they're at. So I think it's also a bit unethical to look at awareness without providing a response. So people are more than willing to talk. We are not listening in their own language. We're not responding in a language of their preference. And I think that's the main shift that we need to make. And in terms of awareness, I feel like it's a bit mental health is a spectrum. What we're looking at, I think what we were speaking about is more severe mental health conditions, which are obvious. They do get identified and, there is a pathway to that particular pathway to care. But what gets missed out is everyday not feeling like yourself. So what we call distress or just not feeling well. We know what to do for physical health conditions. You know exactly what first aid looks like for physical health conditions. We don't know what mental health first aid is. We're not given access to those tools and resources when you're not feeling like yourself. So what are the things that we can do for, that not feeling like yourself, and almost to common mental health conditions, which are typically depression, anxiety, there is a range of interventions that one can do, and those don't necessarily have to be linked to clinical services or a medical paradigm. These interventions are linked to your structural social conditions, and any intervention in reducing the structural level distress will improve your mental health impact. So, for example, one of the interventions that we do for the Atmiyata intervention is linking people to social benefits. If you have socioeconomic conditions improve your mental health, poverty and mental health are extremely interlinked. So structural factors of unemployment is going to impact your well-being, and no amount of mental health interventions will solve that. So we do need to talk across sectors, and there are limitations of what the mental health sector can do. But actually, if we broaden the scope of the interventions, there is a lot that we can look at, intersectorally as well. So yeah, I'll pause there, Aishwarya.
Right. Oh, thank you, Jasmine, for your inputs. We have a really interesting lineup of questions from the attendees as well. So before we move on to that, a final comment or a final line. We talked about challenges, but I would like to know from both of you, what gives you hope for the future of mental health in rural India? Are there any lessons that we can take forward to build a more inclusive and accessible system of care?
What gives me hope is that today, the interventions that can be done for common mental disorders as severe mental disorders has reached a global platform. Whatever interventions can be done outside the country in a developed country, the same can be done here. But the problem remains that the participation is poor. I would think, therefore, the one way to overcome challenge is never give up, persist providing mental health care, no matter how difficult it is, advocate for better mental health services, empower people, even at the level of the National Medical Commission. There has been changes in the way training has to be imparted to get to the young trainee the value of distress, how distress manifests, importance of educating them, getting them to understand distress rather than sitting and reading about distress. Uh, uh, a way forward is to see experience of distress, felt need of the people. That is one. Secondly, we have faltered in some ways by saying that the resource that we require is minimal and therefore that should be sufficient is fundamentally wrong, and we might have to make changes in that. Making use of the Mental Health Care Act, making the system responsible if there are failures in delivery by making use of the Mental Health Care Act could be another domain which can bring about better utilization. While I know that at the bottom of the pyramid there is self-care, then informal care, then primary care, then gradually as things evolve, the topmost of the pyramid is going to be very highly complex mental health problems with sophisticated interventions, and there is hardly training for such problems. But at the bottom of it, more and more people, if they are trained, involved, one resource could be the young people in the colleges and schools who can participate, people who can take time off their work and be a volunteer so that the resources can be increased. And last but not the least is increase the mental health allocation for the country so that some of these things can be achieved. And saying that we don't have money, I think it is a matter of the past. Consistently, whatever allocations were made, they were underutilized, and therefore we need to think of utilizing all the monies that is allocated for mental health care, bring in new ways of addressing mental health problems.
Right. Jasmine, over to you. Same question, a final comment. How do you look at the future?
And what gives me hope? I really think communities give me a lot of hope. I feel communities can do a lot for their own mental health and social care. And I think that is the future, and that is what we need to tap on. And I'm hoping that policy framework also acknowledges and recognizes the role that communities need to play as equal participants of the response, not just as recipients of care, but actually active participants of the solution. And why that gives me hope is because we've designed an intervention which was co-created, and the solutions came from the community. And that is a model that we have been working with. And for us, participation has not been a problem. We work across about 2,000 villages where we have about 2,000 volunteers. And these volunteers are able to reach out to their own community members, have conversations with them. We've done an evaluation on it, so we know that the solutions work. We've created certain quality assurance guidelines, much like any other community health worker would have. So I think there are lots of hopeful opportunities that exist within the communities themselves. And I'm hoping that that can translate to policy interventions as well, for us to rethink and redesign what does a response for community mental health actually mean, without them being even a participant in the response or creation or solution generation. So I think that's a big gap that one needs to fix. And yeah, maybe I'm going to pause there. I know there are lots of questions piling up, so I'll pause.
Yes.